and thank Dr. Chandani for giving this opportunity. I have been working in ASHA from the day one, and earlier to that I was in mental hospital. So my total service is more than 3 decades in this ECT practice. So there are many things to share actually, but a few things I want to highlight. The very common thing in my career, I have seen 10 to 15 cases of choline apnea. Those days it was difficult to diagnose. There was no diagnostic tests available. Now we can do cholinesterase levels and do that comfortably. That way we can avoid choline apnea. And second, very, very rare thing I encountered was pulmonary edema case. One patient, we got a pulmonary edema in ASHA. And patients in convalescence period, especially COVID and this enteric fever, they had lot of problems post-ECT. And some patients also, they lost after shifting to different hospitals. So you should be very careful when you are doing a patient with general medical problems like COVID. Recently, I have been working in LV Prasad also. Patient had undergone a surgery for the eye. He went on well. He came for the reconstructive surgery. After doing the reconstructive surgery, same day during the recovery phase, he had paraplegia on the one side, and we shifted to NIMS. Patient died. So post sequelae, we can't expect what is happening in the patient. The moment patient goes out from our place, we think patient is all right, but it is not all right. After going home, what is happening, nobody knows. Unless otherwise, in LV Prasad also, the surgeons, they want to know what was the condition of the patient. The next moment, what they say, no patient experts, the moment he came out. That means that in such a big hospital also, deaths are occurring means, especially cataract means people think that is a small surgery, local surgery. Nothing like that. Small or big, you have to evaluate completely. Then only we can save the lives. And one more thing, ketamine therapy now we are giving a lot. Everybody thinks that what is their ketamine we can give. We had problems like that. One patient, successfully we had given 6-7 sittings of ketamine therapy. On the last day of discharge, patient had gone to the bathroom and she came out. And just she was lying down on the patient bed. With this even deep stimulation, she is not coming out. I was really afraid what has happened. Just immediately Dr. Chandrasekhar was there, I called him and we have seen the patient. Otherwise, everything stable, but patient is not moving, not responding to the stimuli. After 1 or 2 hours, patient successfully came out. It was just like a simple hysterical type of reaction. And yesterday only, same ketamine patient with some heart ailment. After giving half the bottle, patient had nausea and vomiting. She vomited. 3 sittings she vomited like that, but she is not fit for the ECT. That's why we have gone for the ketamine. So ketamine also caused a problem. Then we had given Zofar injection. After giving Zofar injection, patient had tolerated well, and she's in a better position now. She's likely to be discharged tomorrow or day after. So these are my few things.
Thank you, Dr. Om Prakash. The idea is to highlight the importance of having a good liaison with a physician and anesthetist in running a psychiatric hospital. A lot of times they come to our rescue. Now I leave the topic open for floor discussion, and I think
give solutions to the young generation. There are 2 issues what Dr. Satish Babu has raised. I want to just give some response. One is the gynecologist asking, will there be any problem if I write psychotropic medication in my prescription? Except Schedule X drugs. All of the psychotropic drugs are for the use of registered medical practitioners, not for just registered psychiatrists. So anybody can use it, except the Schedule X drugs. Maybe still they might be hesitant. Then what you can say, you give the prescription. If you want my safety, send the prescription to me, I will just countersign. To give assurance to them, probably they can use it, that's one. Second is about the prison appearance. Nowadays we have invisible grills, which when ASHA Rehabilitation Center has put it, it is invisible. Strings will be there, stainless strings will be there, which provide the security, but not visible at all. It doesn't give any prison appearance at all. If somebody wants to see that, probably can request Jagannath, he will send the photograph to you. Right. That's one thing. And third thing is about, Dr. Kishan has pointed about the establishing nursing homes. So some of the inpatients, they may not need 1 week, 10 days. So can we use the law and get out by keeping the patients before 72 days under Section 94? We can keep under health establishment. It's not called mental health establishment. Section 94 uses the word health establishment, not mental health establishment. So only mental health establishment needs registration under Mental Health Care Act. Others probably we have to register under Clinical Establishment Act. If the rules are more liberal there, probably some of the psychiatrists, young psychiatrists in the districts can start that. But they should not keep beyond 72 hours. No, 50% of the patients we can discharge within 72 hours. I'm very clear about that. Nowadays, beautiful medicines are available. Like suppose I use Zuclopentixol. First 2 days I'll use haloperidol or Zuclopentixol itself. Third day I'll give one Zuclopentixol Acufase, which works for next 2-3 days. I think they'll recover by that time. 50% of patients what we are admitting now for 1 week can be managed by this method. So can we go for this to make it less cumbersome, less affordable? That's what. Thank you.
Now, I think, see, this strategy of using that particular clause in the MSCA, probably it will be more useful if the person is attached to a general nursing home. Because after 72 hours, you are supposed to refer it to a nearest mental health establishment. Suppose if the psychiatrist is having a liaison with another psychiatric nursing home, because once you have taken the responsibility of patient, you cannot tell after 72 hours the patient is not improving, you will be in a soup. The patient has not responded the way you thought he would respond, then the relatives will say, suddenly you can't again tell us to go somewhere. So you should have a liaison with another psychiatric nursing home where after 72 hours you can send. If he improves within 72 hours, fine. No one will have any problem. But a lot of times that sort of a exact timeline we cannot maintain. Yeah, that's one thing. Yeah. Yes. That is
and at the time of admission itself, inform the family members. You can keep the board, no patient is beyond.
What will happen if we play dirty, sir? We admit for 3 hours, 3 days. We refer to Asha for 3 days, then another 3 days. It's done.
You cannot readmit within short time.
No, I won't be readmitting. He's going to a different psychiatric hospital.
To run a psychiatric nursing home, how many patients do we require, like, to break even? I would like to know from you all. Like, if I'm taking a place on rent and I am providing all the psychiatric services, how many inpatients do I require to break even? And when can I expect that break even?
See, usually in any healthcare establishment, it applies to any healthcare establishment for that matter, you have to plan your tariffs depending upon 50% occupancy. So tariffs will be planned as per 50% occupancy. So you should have a reasonable sort of a time period when you reach that 50% occupancy. It depends upon your existing practice. So if 50% occupancy is achieved, then you break even. Because it matches with your tariff, which you, ultimately, the tariff is an important thing in running an establishment. So beyond 50% occupancy when you have, that is considered your profit. So one has to work out a project. So it's basically how you work out your financials.
If if I have to add, actually I would be a little more cautious. I would say plan your hospital for 40% occupancy because there will be festival days where the averages go down way below. So do your costings according to the 40% occupancy. But obviously you have to compare with the market rate just because, and obviously the facility you are giving. The rate in a city capital costs, maybe you need around 15 lakhs, 20 lakhs based on the salary structure you are having and how many administrative staff and plumbers and electricians and all that you want to add on, you can add on to a number. But if you want to be a very economical, it will cost you around 15 lakhs a month. That's for a 50-bedded hospital.
Have a nursing home comfortably. So lot of experience will come. You can manage everything, and you have elders to you can give a call any problem. Your professors will be there, whatever the teaching staff, and your seniors will be there. So comfortably you can run a nursing home. There are problems, but still we can face everything. You can have a wonderful life. Now we're expanding. So now we are having RTMS, rehabilitation services, alcoholic wards. So many things are there. So it is encouraging, and there is lot of problems we are facing. But every problem can be managed very well. Nothing will happen, and we are doing service. If you are having this service, your pocket will be full. Don't bother about break even. To have a service attitude, automatically your pocket will be full, and there will not be a problem. But appropriate. Don't go for 50-bedded hospital. Just start slowly, go slowly, then we'll go to the corporate also. Thank you. Chandrasekhar sir also started like that, humble way. Now it's heading.
I would like to share one experience with Dr. Y. Ganesh. Hi sir, I am Minhaj. We were working together at Apollo Hyderabad, and one case had come from Asha Hospital and not able to diagnose. I think you remember that case. And he was brought to us at Apollo Hyderabad in the ICU, and you referred it to me because it was coming from a psychiatric hospital, and then never on any antipsychotic, only some history of taking lithium, and the patient had NMS, and I did advise CPK, and CPK was in thousands, and we treated that, and my importance of lies in psychiatry, so we could save a life that time. 5-6 cases of NMS, yeah.
One thing I would like to tell the younger generation of psychiatrists is that, unless you actively get involved with the management of serious mental disorders, basically the psychiatric practice, in my opinion, is more about serious mental disorders. Because other minor mental disorders like anxiety or depression or even substance abuse to a large extent can be managed by the other mental health professionals also. If in a community, if there is anxiety or depression or something mild to moderate depression, so you have people who can to some extent complement your services. Whereas in serious mental disorders, the psychiatrists and psychiatrists alone who can handle it. And there is a significant population of serious mental disorders who require the services, both at an inpatient level and an outpatient level. And coming to why I recommend more of an inpatient care too is that there are several recent advances which have been happening which you cannot translate into clinical practice unless you have an inpatient setup. If you cannot translate the recent advances, I don't think there is any future for psychiatry. You can keep on writing papers in journals, but unless you translate that practices into your clinical practice, which is feasible or possible only in inpatient units. So one has to keep this in mind. Otherwise, see, for example, I'll give you a small analogy. Way back when we were students, mental retardation, or what we call as intellectual deficit disorder now, was in the purview of the psychiatrists. Slowly the whole thing went off into outside the purview of psychiatrists. And tomorrow, if serious mental disorders are not taken care of by psychiatrists, there will be managers who will put whatever called, you could call it psychiatric hospital or asylum or whatever facility you call it, and they will just ask your thing. So you will be limited to writing a prescription for a patient who is lodged somewhere. So that should never happen. Basically, the serious mental disorders have to be taken care of by psychiatrists in all its dimensions. It is an acute care, it is a maintenance care and rehabilitation. It is a process. And you have to integrate the recent advances into the care of the serious mental disorders. You may have 1,000 beds in general hospital psychiatric units. I am sure they cannot supplement the psychiatric hospitals. This has been now been realized not on all through the West. You see a lot of literature now coming out of both USA and Europe saying that why did we really close the mental hospitals at all? There's plenty of literature on that. Now they are realizing that they made a large mistake. For example, see, the concept of having a large area for a psychiatric hospital is also very, very relevant. How long you can keep a mania or a schizophrenia tied down to the bed? What happens this is where always we feel that there should be enough space for the patient to go around in a psychiatric hospital. So, so unless more people join, more people open hospitals, these things cannot be implemented. That is the basic idea of saying that we need more hospitals. Hospital-based psychiatry is unfortunately getting sidelined, both at the policy level and at the implementation level by the governments. And because 70% of the health care is in private sector, I think it is at least the private sector which has to come forward and have more hospital psychiatry. This is my personal opinion. And another small thing which I want to emphasize, especially for the younger generation, is that your psychiatric hospitals are not going to be financially unviable. There is no question of unviability of a psychiatric hospital. The profits may not zoom. And never compare your specialty with the specialty of a surgeon or a cardiologist or XYZ. So every specialty has got limitations in the amount of money which you can get. So I see, for example, a physician's income plateaus off after about say 10 years of practice. After that it remains at a plateau level after 10-15 years of practice. But a surgeon's practice may peak sometimes more than the physician's practice. These are all very different issues. But as far as the patient care is concerned, I think hospital-based psychiatry has got a lot of role, and I want the younger generation to actively think about it. In my own experience, a unit which we started with 25 beds, now we could go up to 380 beds. Why? There is a need. When we started the rehabilitation center, I thought 15 beds would be more than enough. It has to become 150 beds. Why? There is a need in the community. Please don't think that there is no need. There is a need, but we are not meeting that. So there is a lot of unmet need as far as psychiatric hospitals are concerned. So it could be either. And another thing, in future it is going to be the group practice, not individual office-based practice. Individual office-based practice is going to slowly diminish in proportion to group practice. These are some of my thoughts.
Yeah, I'd like to just focus upon another aspect is about establishing psychiatric services in general hospitals. I think we all, especially the people who are upcoming psychiatrists, we need to understand that you need to get exposure to psychiatric manifestations of various medical conditions. If you are working in a general hospital setup, definitely you are bombarded with a lot of such cases. And you need to be updated in the knowledge about these conditions also. There will be so many examples like the delirium. Delirium need not always, a person might be taking alcohol, but doesn't mean that is only because of alcohol. There are so many other conditions which you need to evaluate and send back these cases to them. And seizures, alcohol related? No, not always. So, electrolyte disturbances, as Dr. Ganesh was talking, hypernatremia. I've seen case of hypernatremia, patient is appears to be in stupor, sometimes going into coma. So like that, there will be a lot of fluctuations in the level of consciousness, and seizures combined with hysterical fits, several of them we have seen. So like this, there will be umpteen number of examples. I request all of you to kindly concentrate on going to the medical wards whenever cases are there, and then taking a very detailed history, because you will miss, they will send you all these cases. Psychiatric manifestations are very common and they'll just dump these cases on us. Even don't ever think that a HOD of neurology has sent you a case of some hysterical something. Don't think it is hysterical. It can, I have, in my experience, I have seen case of paraplegia, which was because of the ascending Guillain-Barré syndrome. The neurologist HOD has missed it, but then we have to keep our objective mind there. We should not just immediately credit that, okay, it is my case. If you take up such cases, then you will be in a lot of soup. Since there is lack of time, I will not go into such cases.
I don't know. It's not very important, but I'm addressing some people who might not be able to start a nursing home. I am with the wisdom of Chandrasekhar, who said you must be able to treat acute psychotics, so you need a nursing home and all that. That's true. It has its definite place. But as a person who has done outpatient clinical services, partly when I was in government hospital, in the evening couple of hours, and later on, after retirement, I had an outpatient clinic, though I was part of ASHA, a distance and my own some decision problems, I was not going to ASHA regularly, but later on, till Corona, I went for a few years, I was very happy. My patients I could manage very well, thanks for the excellent support I had from management-wise, from Chandrasekhar and whoever were managing the hospital. I only regretted that why did I not go to ASHA regularly much earlier. I would have been much better off. That was a definite wrong decision. But for people who cannot afford to start a nursing home, my feeling is, having worked for nearly 30 years outpatient services only, in a clinic-based services, I had a good number of patients and I had a fair amount of income, not so much as in a nursing home, but quite a good income also. If you are moderately empathetic to the patients, many neurotics, many psychotics, I have treated outpatient-wise many alcohol problems. I was fortunately trained in an outpatient psychiatry, not outpatient psychiatry, but non-mental health hospital setup, general hospital psychiatry. I was trained, and so I felt quite happy with dealing with the patients. Number of patients used to come. I had a fair amount of income also. So people who cannot afford to start a nursing home, there are definitely problems, as you know, in a nursing home. You need not be pessimistic. With a clinic, you can survive very well, unless you want to have huge money. That's a different matter. But a fairly good amount of, you can sustain yourself fairly well I'm addressing that population who cannot organize psychiatric services in a mental hospital kind of a setup. You don't have to feel, you can, as a clinic-based services, you can be very successful. You can have good number of contacts and all that. And in fact, at some point of time, after a few years of retirement, one day I was driving with my wife. I said, in this city, I was for so many years as superintendent and all that, I thought I should start a nursing home. I thought I'm obliged to this city, and I took the advice of Dr. Chandrasekhar also. What all I planned in one day, he changed so much, and it was a very good advice. But for some other reason, again, I backed out because I was not thinking that I am for a mental hospital kind of an approach. So I'm only saying that because the number of postgraduate seats have come up such a lot, so a fair amount of people need not be frightened. They can have a clinic-based services and survive very well. That's what all I want to say. And I have enjoyed my services. For some years, I practiced in Asha. Chandrasekhar knows, others know. I have enjoyed services very well. I had never any problem because management was by somebody else. Thank you.
Right.
Sorry, Chandrasekhar, kindly don't take.
No.
Right.
See, the idea is not that there is not going to be good outpatient practice or earning, all those things. The idea is not that. What I am trying to emphasize is the relevance and the role of hospital-based psychiatry in the current day thing. A person can earn and be a very good psychiatrist by office-based practice. No doubt about it. The idea is to only to emphasize that in the long run, if you are neglecting the hospital-based psychiatry, as see the government is also not encouraging hospital-based psychiatry, what is going to be the future of seriously mentally ill people? That is my concern. What is going to be the, then we may get into the various other practices where the mentally ill are kept in places which are not really psychiatric hospitals. They may be wandering more, increase the wandering lunatics, and so on and so forth. So the idea is that as a specialty, psychiatry should be able to focus on hospital-based psychiatry.
That's a very good foresight, and that is our duty to manage this hypothesis. It's also there.
1 minute, I want to appeal to the younger psychiatrists because I was asked to speak about the problems of standalone hospitals in districts, but you all the young psychiatrists can start because I'm happy with my hospital, so you will be happy with your hospital if you start nursing homes. Don't get discouraged by what I told. Thank you.
And he's
Just I
very
want to
prosperous
add
also.
one thing,
He's
sir.
very prosperous. And new districts came in Telangana. Lot of districts still not having psychiatrists. So this is for young generation psychiatrists. One request to the senior psychiatrists who are already well off should start alcoholic wards because this is taking away by other people, non-psychiatric people. And child psychiatry is taking away by this rainbow type of hospitals. One hospital came, Karimnagar, pediatrician is taking care of all child psychiatry problems, he is writing treatment. And now I'm opening a child psychiatry ward, child psychiatry clinic, Prashant Child Clinic. My old premises are converting to, because we are better than them. So this market is going after. 100 members are coming, sir. Our market should be protected and should be shared to young generation. Thank you.
I think we should not be so insecure. There is a market for everybody. Ideally, if you want a quality life, preferably go in for a group practice. Makes your life so easy. But if you feel you're dynamic and you want to do it your own solo game, yeah, that's also welcome. And don't be afraid somebody else will take away your practice. Remember, no physician, no hospital, general hospital will be able to handle a patient with alcohol delirium whom we give 350 milligrams Librium. You put that, next minute he'll come cancel that and start, because they are under that impression that benzodiazepines will cause respiratory arrest. So don't be afraid. We have our own specialty, nobody can take it away from us. Our skill set, but we should remember that primarily we are physicians. So as long as we remember to rule out differential diagnosis in our brains, we are good, nobody can take away that from us.
And one more small adding point. Some people are thinking that if you have the group practice is one of the good way. And even I am staying since last 3 decades. I'm staying upstairs. I'm comfortable. My both children are upstairs psychiatry.
Now it's group
so
practice.
if you, that is now is a group practice. no, you see, still I am staying in the upstairs.
practice.
So quality of life cannot be disturbed. Every Sunday you can close, you can have weekends, you can enjoy, you can fly to different countries if you are really good service. And lot of the problems will be solved if you are in upstates. Lot of the problems. So these suicidal attempts, so many problems will be avoided because you are morning you will do rounds and go, night, afternoon also you will do rounds during lunch time, night also you will do rounds. So lot of problems will be prevented. We are very comfortable with that. And it is upon the mindset of the people. Okay, thank you.
Sukhamane rogam.
Sir, right, sir. I take your point. Sukhamane adi okati, and also group practice. So working in like a liaison setup in hospitals. I'm from Care High Tech and KIMS Kachipoli. Now, for me, the problem is if I have to start an inpatient, I'll tell you, I don't know whether I can talk to on behalf of all my generation. With every 10 years of generation lowering, we have less tolerance to other person. We have our own self-individuality. Working in team is becoming very difficult. Even if there are 2 doctors or 3 psychiatrists within the group, the corporate knows how to press your buttons. They know they don't pay you, but they expect you to stay a full day. Okay, it's a fee for service. They take the insurance and it cuts from your pocket, and they don't pay anything. And if you start talking anything, they know how to use the junior most doctor to put the highest one. And people also now know how to use the media, how to use Instagrams and all this. So it's not about what you may think, I'll do my practice, I'll put my head down, I'll just do myself. That doesn't work, because whoever makes the big sound will be the one who everyone thinks is the loud person or the most talented one. That's how it is. So you don't want, it's as I always say, heart is very fragile. You don't want to put yourself into those kind of things and then feel sad, bad about those things. Rather, do your own clinic and go off. If I need any holiday, if I have to go for my kids picking up or anything, I'm not answerable to the corporate. So I have put myself into that fee for service. Now they are very comfortable. And it's like, the more if I ask, or if I say we want to set up, then it becomes an emotional burden on us that we have to do something. So it's not easy, sir.
I totally get your point, but we have to remember 2 things. One, we are in the field to do our profession to our satisfaction. That should be our priority. Forget about the administrative issues, bureaucratic tapeism, the bitching about, if I have to use the term, that happens. That will be there in every field. Even in your house, it will be there. So that should not be a reason to say, I don't want to do, I want a comfortable life. If you have your prior main aim clear, that I want comprehensive, I want to use the full extent of my skill set to be used for the benefit of the patient, then ideally you should have a hospital setup. It doesn't happen without that. The moment you have a hospital setup, you will have a team where there will be other allied professionals without whom you can't do it. So those 2 things are important. And as far as you are concerned, you're thinking, okay, I will make focus and then that's it. Beyond that, I don't want to take the responsibility. That is also perfectly fine. See, we are psychiatrists. We have to focus on our primary mental health first. So if you are comfortable, yes. If you're not comfortable, also yes. Because it might be an opportunity for you to grow. Okay, stress is one of the reasons. So don't be afraid. One thing, if you generally believe something is out to be achieved, achieve it. If there's trouble, There are always colleagues, seniors, juniors, friends who will be there along to support you. So don't be afraid. And if you can't use it directly, use an alternative service. Somebody else has formed a team. Refer your patient, get them treated. You do your primary treatment indirectly. Get the patient back to your OP. The patient is benefiting. You are benefiting because there's a comfort. The other group is benefiting because they're getting an admission. So everybody benefits. And there are two ways of looking at starting any venture. You can do it professional, pure businessman-like, which most corporate hospitals will do. That's why no corporate hospital will have a psychiatric department, because it is not revenue generating for a hospital setup. What we do for 1 month, our investigations will be 20,000-30,000 rupees bloods in OP. One physician will do that in a day. So there is no way we can compete with a general hospital setup. We are just a sideline which they have to tolerate. So we don't focus on that. We focus on we are irreplaceable for that 1%, otherwise he will have a problem. When he has a suicide attempt by a patient, he has no choice but to come to us. So we are secure, don't feel afraid. And the other thing I was talking about was the business enterprises. One is professionalism, the other is social enterprise. So most psychiatrists, at least even Asha when it started, I'm sure was more a social enterprise. Now you can become commercial, that is different, that's a choice. But social enterprises are what we need to focus on. We need not be profit oriented. If you want money, there are n number of fields in the world to make money. But the satisfaction you get in your own medical field is high. In the medical field, again, you have tiers. So don't be afraid. If you really feel, have a parallel field to generate your income. There's no problem there.
Sir, I would like to differ from Chaudhary sir. Even in a single clinic, you can earn good amount of money. And as you said that seeing psychiatry as business is not profitable, or in any corporate won't take up psychiatry.
Name one hospital which has a psychiatric department independent of other departments, sir, it has inside other departments.
I'm coming to that, sir. We have one psychiatrist among us. We have Dr. Chandrasekhar, Dr. Jagannath, who had opened a corporate-like psychiatric setup.
No, you didn't get my point.
I got your point that a general hospital won't have, yeah.
In comparison with other departments, yeah. That's all.
There is this one guy coming up from Maharashtra, Amar Shinde. He has opened multiple centers across the country, psychiatric centers, psychiatric services, almost 8 centers. And there are people, I would like to tell all the youngsters that there is a spectrum from starting a standalone clinic to opening a corporate hospital, a psychiatric setup. So we can go from that, we can have a child psychiatric clinic, we can have cognitive behavior therapy clinic, just clinics to small nursing homes. And I would disagree with you that we require 15 lakhs a month. I was talking to Dr. Rajesh and Raghavendra of Sukoon Hospital. They are running psychiatric services, inpatient services, and they require around 3 to 4 lakh rupees a month to run a small nursing home, not a corporate hospital. I also run a nursing home and I have a clinic. So we don't require that much amount and we can generate good amount of money. Dr. Usman Ali is there, he would agree with me. कितना लगता है भाई महीने का? 3 lakh. 10 bedded 3 lakhs. And you can generate that much amount? Ji. So, no,
they should.
There is
I think I get your point, but the point is, you start a 10-bedded unit, how many clinical psychologists can you use? How many remedial educators can you have? So you have to then send your patient varied places. We're talking of comprehensive services. You cannot have a comprehensive service unless you have a certain amount of care. And then when you say 50 bedded, whether you like it or not, you have to have X number of nurses, X number of ward boys, X number of current issues, plumbing issues, maintenance issues, SFT. Then I'm talking of hospital which according to rules, every ward has to have its own eating place, dining section separate, patient separate, individual space in the thing. That is all adding up to the commercial cost. When you do a 10-bedded center, you will compromise a lot. And when you have an established center, you have to have fire safety regulations, other issues come in. So costs increase. Single-bedded room, for a 10-bedded unit, you'll have 1 floor. You don't need fire.
Smaller setup is becoming very difficult day by day. 10-bedded, 10-15-bedded nursing home is not so easy to run in hospitals.
That is individual. See, individual choice. I can run a 4-bedded unit and feel I'll run everything. I'll be the ward boy. I'll be the nurse.
I think we should have a separate discussion on the financials. There's a different ball game about the financials. Anyway, I think we had a fairly interesting floor discussion. Thank you one and all. I thank Dr. Alim Chandani for having invited me to be the moderator for this session. I thank my co-panelists, Dr. Chaudhary, Dr. Kishan and Dr. Satish. Thank you one and all. I close this session.
Thank you to the moderator and the panelists for an engaging session with wide range of opinions. I would like to request the panelists to present a memento to Dr. Chandrasekhar sir. I now request Dr. Chandrasekhar sir to present a memento to Dr. P.K.N. Chaudhary sir. I request Chandrasekhar sir to present a memento to Dr. Satish Babu sir. I request Dr. Chandrasekhar sir to present memento to Dr. P. Kishan sir. Thank you to the moderator and the panelists. A note to the delegates, tea and accompaniments have been served. I would also like to have Dr. Chandrasekhar sir present a memento of acknowledgement to Dr. Ganesh and Dr. Om Prakash sir. Note to the delegates, tea and accompaniments have been served outside. Please feel free to have at your own convenience. So following this engaging panel on psychiatric nursing homes, we now shift our focus to the final session of the conference that resonates with the changing landscapes of our digital age. The honored chairpersons for this session are Dr. Praveen Chintapanti, whose current work is in artificial intelligence in psychiatry and allied fields. Welcome, sir. Prime Hospital and Shravani Hospital. Welcome, sir. And welcome Dr. K. Ashok Reddy, sir, Professor and Head of Department of Psychiatry at SVS College, Mehboob Nagar, Telangana, who will guide us through the establishment of digitalization services in psychiatry. I hand over the dais to the chairpersons.
Which makes us to have digital prescriptions and also to keep, to digitalize all the documents and also to keep the documents at least for 3 years. So to talk more about this, about digitalization services in psychiatry, we have Professor Ashok Reddy sir with us. Professor Ashok Reddy sir is currently the professor and HOD of SVS Medical College in Mehboob Nagar. He also worked as a faculty for almost 3 decades in IMH Hyderabad. He is also founder director of Government Medical College in Mehboob Nagar. His areas of interest are community mental health education, rehabilitation of mentally ill, and use of IT services in psychiatric practice. So I still hear from my seniors and colleagues that the people who are sitting on the right side of me were the first two psychiatrists in Telugu states to use computer systems back in 1990s. So I give my thank you for making me one of the chairpersons, sir. I will hand over to the Praveen, sir.
Thank you very much indeed, Dr. Chandani Saab and the entire team for this beautiful topic. I know lots of people are having the tea break. I think they should come in because this is something you don't have a choice but to know, because tomorrow you cannot practice without understanding the digitization, and with things evolving much more rapidly with ChatGPT and other things happening, you cannot really blind yourself to the situation that I'm going to give a pen and paper prescription or forget about, like, I'll see the patient and then give a prescription. It's going to come back and bite you someday. I think Dr. Ashok Reddy Garu is going to take us through primarily what is that I can do today and what's the scenario for future. Perhaps that's something which Dr. Reddy Garu will take care of. Thank you, sir.
Very good afternoon to our chairpersons, all the faculty, speakers, organizing committee, and the delegates here. Today I want to present about digitalization of psychiatric services. I am selected to be here because I have started using the digitalization way back in 1995 itself. I'll briefly tell the few experiences, then I'll go to the topic proper. By the time probably the delegates who have gone for the tea also will join. See, I started the first, the medical record itself I started using from 1992. I used to allot one paper for each patient in my OP and write every detail in that. Whenever they come again, I used to open the same page and then start treating it. So to unburden my own brain, I never remember about any patient. That I used to do only in the first 2-3 years of practice. After I said, all your information is in the records, not in my brain. So no patient should disturb me when I'm out of the clinic. Your service is only when I'm in the clinic. That's a policy I'm following for the last 35 years. So these records which were there on the paper for 2-3 years, I thought I should convert into digital. That's how I started. So I sat with one of my friends who is in IT, and both together sat and prepared the first program that was based on DOS system initially. Disk operating system was used at that time. So we jointly prepared the program wherein we can enter the medical records into the computer and then start using it. So whenever the patient comes again, just click open the record and see it. That was how the journey started. Then after 3 years of my practice, I introduced one small concept called learn while you earn in my clinic, because there was some deficiency I could find in the training at IMH. Because in IMH, what used to happen is cross-sectional evaluation is done, but PGs never had the longitudinal information about any patient, because next time when the clinic patient comes to the hospital, he is seen by some other person, not the same person. This was lacking. So I just started in my own clinic, giving another independent chamber, the junior psychiatrist. So they used to evaluate the patient. When the patient comes, they'll prepare the case, everything. Then they come to my chamber. We used to manage like this. So I used to pay some honorarium to them. They used to assist me, they also learn. Because now they have the access. What happened 6 months back, what happened 1 month back. They can see on the computer, the total follow-up. That's how I started. So when I started using 2 computers now, the DOS operating system doesn't work. So we have to shift to the next system. And then again, I've taken the help of another person to change the total program without losing the previous records. It's transferred now. So through LAN, that is linking up 2 computers. So my assistant as well as me were able to see the medical records are managed. That's how we went on for some more years. But after some time, I have to practice in different places. Not in one building having 2 chambers, but distant place. The second system doesn't work now. Records have to be available online, on the cloud. So now I have to go to a third type of program. So in this program, all the records are stored in the cloud. I can access the records from anywhere using the internet. I can access through my phone, laptop, desktop, anywhere. This is how the third shifting has occurred in the medical records and management. Now I'm running one clinic at Shadnagar, Rural Mental Health Service. Even there, my records which I have seen in Hyderabad are available there. I can just access, give the prescription, send away. Same patient can come to Hyderabad. And some of my patients I'll admit in Asha Hospital. Recently I stopped almost going to Asha Hospital to see the patients. Reason is my daughter is working there. So once the patient is admitted, she will take care of the patient. So she can access my records of the OP at Asha Hospital and continue the treatment. Once patient is discharged, again they come to clinic and continue this is how the system is working. I want to just show the advantages of how it's going on. I think people have come back from the tea. I'll go to the formal presentation now. So the scheme of presentation will be, I'll be talking about what do you mean by digitalization, how it is done, what are the advantages, what are the disadvantages, what are the areas of psychiatric services where digitalization can be done, what are the requirements for digitalization, laws and ethics of digitalization. Here two words are used, digitalization of services and digitization. They have slight different meaning. Digitalization is about total process of converting your clinic itself, service itself, into the process of making online. The total process is called digitalization. But digitization means just converting the data which is available in the form of written text in the case sheets or oral communications, making it digital form. That's called digitization. What I told you, initially I used to maintain the records on the papers, but I converted into computer records. That's called digitization, that simple process called digitization. But converting the total process of management itself is digitalization. Where to point us? Data has to be entered. What are the various methods available now to enter the data? Simply you can use the keyboard and enter the data. You can write on the writing pad what Dr. Pramod has explained in the morning. On the iPad he writes, it goes to the storage. Third is the pens or tablets. Even smartphones we can write or type it and convert all the records. That's how you can enter the data. And of course it is processed and stored in the computer itself. Or scanning can be done. You can just take the records, just scan and store it. Or mobile phone scanner you can use. You can just take any laboratory investigation is brought with the patient, you can just use your mobile phone, just scan, transmit to your computer. So you can just transmit the data like this. Or dictation. Now when dictation is available, when the Google document there is a dictation provision, you can just dictate, it will convert into a text form. So all these methods are available now. Even to a smartphone you can dictate, it can convert into text. So whatever is feasible to us we can use. So many methods are available to enter the data into the computer now.